Good evening, everyone, and welcome to the beautiful surroundings of the Sheldonian Theatre for the Centre for Personalised Medicine's annual lecture. And thank you for coming through the weather as well. It's not been easy to get here, I think. So my name is Annika Lucassen. I'm Director of the Centre for Personalised Medicine, or CPM, and I'm Professor of Genomic Medicine at the University of Oxford. Before I introduce tonight's speaker, I wanted to briefly introduce the CPM to anyone who is not familiar with it. We are a communication, engagement and research initiative based at the University of Oxford as a joint venture between the Wellcome Centre for Human Genetics, part of the Nuffield Department of Medicine, and St Anne's College. We are funded by the Stanley Ho Medical Development Foundation and the Wellcome Trust. Our aim is to communicate, engage and research a wide range of aspects of personalised medicine with students, academics, scientists, policymakers, and members of the public. Much of our research looks behind what is celebrated in the headlines as advances in science or healthcare and tries to add nuance to the debate. We host a wide range of events, blogs, vlogs, and podcasts, and they are all there on our website. We've been so productive, our website is a bit overloaded just now, but look out for a fresh new one later in the year. We also have a remit to engage with audiences in Hong Kong, Macau, and the Pearl Delta region of China. You can find recordings of our previous talks, including those by Andrew Hattersley, Jennifer Doudna, Adam Rutherford, and many others on our website. Please also follow us on Twitter at CPM Oxford to find out about our activities. We are really delighted to welcome Professor Mary Dixon Woods to give tonight's annual lecture. Mary is Director of the Healthcare Improvement Studies, the great acronym of this, Institute. Mary is also the Health Foundation Professor of Healthcare Improvement Studies in the Department of Public Health and Primary Care at the University of Cambridge. Mary's programme of research is concerned with generating the highest possible quality evidence base to support improvement in the organisation, quality and safety of healthcare. Characteristically using mixed methods approaches, her work focuses on evaluation of quality and safety improvement interventions and programs, culture and behaviour in health systems, and regulation and governance of health research and care. She has a special interest in methodological innovation in the study of healthcare improvement. I first met Mary on a regular Wellcome Trust review panel where her astute insights and analyses were a thing to behold. She's been long on my personal wish list of plenary speakers, and I'm really delighted she has agreed to give our annual lecture this year. Mary's lecture is entitled, Putting the Person into Improving Quality and Safety in Healthcare. After the lecture, there will be time to ask some questions, so please leave your questions till the end. And now it just leaves for me to hand over to Mary. Thank you, Mary.
Thanks so much, Annika. Lovely introduction, and I'm absolutely delighted to be here this evening. I'm going to start my talk where many talks on health services research start, which is with a brief history of variations in care. And I'm going to start particularly with Tonsilgate, which is a controversy dating back over 2,000 years and concerns the extent to which surgery is an effective intervention for chronically inflamed tonsil, a debate going back to the time of Gowan, but first started to get scientific epidemiological attention in the early part of the 20th century through a wonderful character called James Allison Glover, who began to document variations in the extent to which children were being subject to tonsillectomy around the UK. This paper, I think, is a marvel in many ways, published in 1937. And essentially his argument is that the rates that he was seeing, the variations in rates of interventions that he was seeing were open to criticisms. And he points out, for example, that a child living in Rutlandshire or the Soak of Peterborough is 19 times more likely to undergo tonsillectomy than one living in Cambridgeshire. He concluded that if you looked at areas in different areas which have that there is striking contrasts in areas apparently somewhat similarly circumstanced. So even though the populations appeared to be very similar, they were having vastly different rates of tonsillectomy. So in that year, the operation rate in Margate was 8 times that of Ramsgate, and in Enfield 6 times that of Wood Green, and 4 times that of Finchley. Now, this was non-trivial. There was also an 8-fold variation in death, and in one 4-year period, over 500 deaths following tonsillectomy. And Glover concluded that the answer to this problem of what appeared to be entirely unwarranted variation was what he called true discrimination. And he argued that, that all subjects for operation should be selected with true discrimination to avoid the tendency to perform it as a routine prophylactic ritual for no particular reason and no particular result. So a very provocative analysis. And one question might be, well, surely the children were more healthy having undergone their tonsillectomy operation. The prevailing view at the time was that it was a form of hygiene. In steps Leah Manning, and I'm very proud that she was a graduate of my college in Cambridge at Homerton. And Leah Manning was responsible for the evacuation of nearly 4,000 children from the Spanish Civil War. These children were brought to Southampton, where some of us are from this evening, and there were medically examined and the results written up in the Lancet. Now, these children turned out to be in rude good health, but had a tonsillectomy rate of just 2%. And Glover was actually concerned that they might, having come to England, end up still having tonsillectomies. And he says it might well prove disastrous if these were to be removed. So he's actually quite bothered that these very healthy children, completely fine without tonsillectomy, might end up having it. So he concluded that the variations that he was seeing defied any explanation save that of medical opinion on the indications for the operation. Now, as we'll see, this view that medical opinion was the thing that was driving the variations has remained remarkably persistent. Jump forward a bit to the middle of the 1970s, and Glover inspired an epidemiologist in Dartmouth College, where I was very lucky to spend a year, to do this, again, remarkable study of small area variations in healthcare delivery. And sure enough, discovered pretty much the same thing as Glover, a massive unwarranted variation, including a 17-fold variation in rates of tonsillectomy in different parts of Vermont and a 6-fold variation in hysterectomy. And his conclusion was that this is unwarranted variation, which he defined as variation that cannot be explained on the basis of illness, medical evidence, or patient preference. And as we shall see, all of these things begin to play into the story of what you do about variation. So one answer to the problem of unwarranted variation is to do a lot better with true discrimination. Only do things to people if they're likely to benefit might be the story here. But we immediately begin to run into problems as soon as we try to execute this mission of personalizing care. And we run into the problem that personalizing care as imagined is not always the same as personalizing care as done. And we can see, the same kind of phenomenon arising as our medieval artists tried to represent animals. So this one, can you guess what this is supposed to be a particular type of animal? Can you guess? Camel. Okay, very good. Not a duck. This is an elephant. Okay, that is a lion. Very good. That's a tiger. And finally, for now, that's another elephant. Now, we're going to see the same phenomenon. People try to do something, but it doesn't always work out as you would hope. So the one issue is that the effectiveness of personalised efforts to target care on those who can benefit is highly variable in practice. If we look, for example, at the phenomenon of clinical prediction models, and as we'll see, clinical prediction models litter the literature. There are thousands of these things published every year in all kinds of fields. One of these fields is psychiatry. Very nice systematic review, identified zillions of them, and it says that essentially the success of these models is based on assessments of their statistical accuracy rather than tangible improvements in care. Most published prediction models in the medical literature never reach clinical practice, and the same appears to be true for psychiatry. We found virtually no peer-reviewed evaluations of whether implementing these models in routine psychiatric care conferred sufficient improvements to patient outcomes. So we have a phenomenon of what appears to be a description of something that might help patients but never actually ends up benefiting anybody. And trying to turn many of these prediction models, wherever they come from, into something that actually works turns out to be unbelievably difficult. A very popular idea is that you can reduce admissions to hospital, readmissions to hospital. You can reduce burden, as they call it in healthcare, by finding people who are high users of care and supporting them so essentially they manage better. The literature on this, when it's subject to test, is really quite depressing. So a very nice study published recently in the New England Journal on the concept of healthcare hotspotting. Find the people who are super utilizers, focus care on them, and the idea is that you will keep them out of hospital and they'll do better. This randomized controlled trial of patients with very high use of healthcare services found no difference in readmission rates compared with those getting usual care. If we look at this, again, very nice study from our colleagues in the Health Foundation, looking at, again, something that appears to be a jolly good personalised idea, an integrated care pathway for patients at high risk of emergency inpatient admission. Even more depressing results. This did not reduce healthcare utilisation, was associated with an increase in elective inpatient admissions and an increase in GP workload. Another very nice study, a randomized step-to-edge trial looking at effects and costs of implementing predictive risk stratification in primary care. That was associated again with increased hospital emergency admissions and increased use of other NHS services. Now, it may well be the case that what you're doing is finding unmet need and helping those patients, but it's not doing what it set out to do, which was reduce services. Nonetheless, what we get consistently with clinical prediction models is a tendency towards hype and over-optimism, this constant promise that the next one is going to help patients better. And the same pattern is repeated, not just for clinical prediction models, but anywhere you come across concepts of finding patients and then turning this into something that is going to produce benefits. So Annika, super paper in the BMJ recently on polygenic risk scores made exactly the same argument. And my own brother Porig has pointed out that the impacts of polygenic risk stratification are not necessarily proven when it comes to cost effectiveness. Why does this happen? I'm going to talk you through true discrimination and its troubles. And there's a kind of natural history to personalized interventions and their pathologies. And this natural history has three parts. One of it is research waste, a second is design waste, and the third is improvement waste. So starting with research waste in personalized care, the point of clinical prediction models is to try to individualize risk estimation for clinical outcomes using multivariable risk profiles, which sounds like a very good idea. And the idea is that you're going to distinguish those likely to develop the outcome from those who won't. The promise is it can be used as a basis of structured tools to support diagnosis, prognosis, and prediction of response to interventions. We have very good guidance developed by your colleagues here in Oxford on how to report clinical prediction models, but nonetheless, the reporting of these models is often poor. I've used the polite term here, it's often terrible. There are multiple problems with the studies in the published literature, including weak designs and study conduct, and many of these studies are at very high risk of scientific bias. So that's a whole lot of waste in its own right. But add to that the volume of these things coming out. So a systematic review in the BMJ very recently identified over 600 prognostic clinical prediction models for COVID-19 alone, and also concluded that most of them are at risk of bias. So this is waste on a phenomenal scale. The review concluded that much of the work done to analyse all the data has been ill-informed and disjointed. And it's not just scientific bias, we're also building in other forms of bias into many of these forms of prediction. Many will be familiar here, but something as innocent as the APGAR score, which has been around for a very long time, appears to be less effective when it comes to babies with darker skin. And we see the same kinds of structural biases affecting technology too. Pulse oximetry, which was of course an extremely important technology when you're caring for very ill patients, including people with COVID, again systematically underestimates illness in people with darker skin. And we see the same kinds of biases and discrimination built into models of care. So I think some of what happens with prediction models is that they're actually, in fact, excluding important information. So although they're claiming to be personalized, they have not actually got the person at the center. And one thing is that they are almost entirely based on clinical data. And I don't often quote from John le Carré, but I think he was quite right when he suggested that a desk is a dangerous place from which to watch the world. You don't get all of the information you need by looking just at clinical records. And in fact, we see the same pathologies affecting the clinical records and quality standards. If we look, for example, at perioperative quality and safety indicators, an area where massive need for improvement. Again, we see the phenomenon that clinical indicators are prone to entropy. There are nearly 1,300 different clinical indicators in this area. Over half of those in use have no level of evidence described in the literature, and very few are patient-reported or measure domains that patients would see as important. So we have a phenomenon of massive research waste that does not help the cause of trying to personalize care for the benefit of patients. The second form of waste is design waste. And this arises because turning a model into a tool for personalized care is an extremely complex task that is often done in a really quite amateurish and ill-coordinated way. So let me talk you through a short, and I'm sorry to say, very sad history of personalized approaches to patient deterioration. And this arises in many contexts, but one of them is acute care in hospitals. And the big national audit found that about 75% of people who underwent CPR in hospital had a period of physiological instability before arrest. They suggested that about 2/3 of those cases were predictable, nearly 40% were potentially avoidable, and that some had received multiple reviews, but the deterioration was still poorly recognized and managed. So in other words, the argument was that there are patients deteriorating in hospital, you could identify them on time and then intervene to support them so they don't end up getting much sicker in intensive care or a worst possible outcome of death. Around the same time, a very important paper looking into preventable deaths in English acute hospitals found again that poor monitoring in response to deterioration was one of the major contributors to avoidable deaths. So again, a kind of form of true discrimination might be what you're after here. And the response was to develop track and trigger systems for deterioration and response to deterioration. The principle is simple. You keep the patient's vital signs under review. You have thresholds that will trigger action, and then you can mount a suitable response and take suitable action to stabilize the patient. So that was what was supposed to happen. Let me ask you to guess the animal again. I've had goat and horse. Not a bull. That's a giraffe. And we see, again, the hope not entirely turned into reality when it came to track and trigger systems. Early warning scores were promoted as the way to go. There was a massive proliferation of early warning systems throughout the 2000s. Pretty much every hospital came up with their own way of doing it. We were studying it at the time. There was a huge amount of effort invested in this at local level. And the result was, in fact, massive, unwarranted variation with very little validation of any of them. When the Royal College of Physicians attempted to address this through national early warning scores in an effort to standardise it, but it's still the case that about 20% of hospitals are still using their own system rather than the national one. We see the same phenomenon happening with paediatric early warning scores. There are, again, dozens of these out there, but this nice review looking at 7 different paediatric warning scores. This is just in one country, by the way. This is not internationally. This is just in the UK. Multiple locally developed systems in use. They differ on the variables that they're measuring, the thresholds and the escalation algorithms, to the extent that a score on one of them, I can't remember what it is now, but it's either 5 or 7, means the child is ready to go back to the playground, and on the other one means they're ready for ICU. So massive confusion. This obviously complicates all kinds of aspects of care of patients and transfer, and you create all kinds of risks associated with different staff training and experience. Obstetric early warning scores try to do the same thing. Again, one of the biggest contributors to poor maternal outcomes is failure to detect that the parent is deteriorating. This study found that there are nearly 150 different early warning scores and escalation policies with 2 major approaches. One of them uses one version uses a weighting system, the other uses color coding. There's massive variation in what's considered to be normal, the thresholds, and the nature of the required response. So to give you some examples, in half of the units, the temperature was considered to be abnormal, severely abnormal, over 38. But in 6, they only thought temperature over 40 was only considered to be mildly or moderately abnormal, and below 35 was considered to be severely abnormal in only 2/3 of units. Most units considered a respiratory rate below 11 breaths per minute to be severely abnormal, but in 22 units, a respiratory rate below 9 breaths was considered to be only mildly or moderately abnormal. So this is not a sensible way of delivering personalised care. And even then, the tool is only one bit of the component of the system. It's necessary but not sufficient. If you're going to do personalized track and trigger systems, you have to have a whole end-to-end system, which includes not just the tool. You need a structured system to support timely recognition of deterioration. You need a process for calling for help, and you need a response system. And you need a whole infrastructure around that: teamwork, training, and all of the work system designed to ensure that this is actually going to work. So what we actually end up with is excessive focus on the tool component, and that leads to essentially to magical thinking. We think using the tool is going to produce the outcomes, and it very, very rarely does. And this is something we have studied in multiple contexts. About 10 years ago, there was a lot of excitement about a tool that appeared to decrease catheter-related bloodstream infections in intensive care units. And the claim at the time was that this was all down to a simple checklist. There was a very famous article in the New Yorker that claimed that checklists were now the answer to all forms of patient safety problems. And by studying that program, we were able to show that the checklist certainly had an important role, but it was far from sufficient. And there was a whole culture and a whole set of systems that were really important in contributing to the reduction seen in bloodstream infections. And failure to understand that has real consequences. So when they tried to reproduce that program in England, it did not produce the same effects because they did not reproduce the same mechanisms, and it therefore did not yield the same benefits for patients. And as part of that approach to whole systems, The thing that often gets forgotten is that the conversations and the relationships between the team caring for the patient, but also critically between the professional and the patient, are absolutely key components too, and they often get the least research attention, I think partly because they're just seen as being fluffy and the kind of thing that you just know how to do intuitively. The third form of waste then in personalised care arises because we haven't got the infrastructure for figuring out what we do, how we do the improvement work once we have identified that there are problems. So Glover was very insistent that it was medical opinion driving the variations, and that if we could just get doctors to change their minds, things would all be better. That is the basis of audit and feedback, which has been a very significant improvement strategy. In fact, I would go so far as to say a dominant improvement strategy in the NHS, and has had probably more attention from a research perspective than virtually every other improvement approach. The systematic reviews basically conclude that you get small effects using audit and feedback. So you're basically collecting data on, for example, what the doctor is prescribing, feeding it back to them. They're then supposed to realize they're an outlier and change their ways. You can't really solve most problems through this approach. You can get some small effects up to about 7%, but in fact, it's nil on some of them. And it's now clear that most variation is not actually caused by a variation in professional opinion, and that's not going to be the way we solve the problems. In fact, I think it's distracted us. An excessive focus on professional behaviour distracts from really important issues of structure and process. So one of the founding figures in improvement strategies, which is what I study, is a character called Avidus Donabedian. And it's a very simple idea, but a very important one. He says outcomes depend on structures. Structures are things, and they might be payment models, they might be buildings, they might be level of staffing and so on. And processes are actions, and that will include communication, it will include teamwork, it will include how you're talking to patients and families. Structures and processes produce outcomes. And in the policy world, there is often a huge amount of interest in structures, and we're seeing this at the moment with the emphasis, for example, on staffing levels. And there is absolutely no doubt that you cannot have a good health system and you can't have good care for patients if the structures are not right. And deficits in structures certainly explain some of the variations that we're seeing, very importantly, actually. So if we look at something like a comprehensive geriatric assessment, so in a moment of cheer, this is an approach that actually does work. It's a phenomenally effective intervention. It's basically creating a personalized assessment of an older person. It's very closely focused on their goals, and it seeks to coordinate multidisciplinary care around their goals. Now, Cochrane reviews typically conclude by saying we don't have enough evidence to say anything, but in this case, even the Cochrane review says it works, and even the economic evaluations are positive. We nonetheless have variable implementation of comprehensive geriatric assessment. This does not arise because of any lack of evidence that it works. It often arises because of deficits in structure, financial incentives, staff availability, and so on. But it's also linked to process problems. And I want to really stress that not all of the variability can be explained by variability in structures. So even if tomorrow we somehow manage to find enough staff for the NHS and beautiful buildings, we still would not solve the problems of variations in care. So let's have a look at processes, and we'll return to monitoring and response to deterioration. So it is clear you have to find the right patients, and you need to focus your efforts on those to rescue them. But what we see in the literature is that when you compare organizations and units that seem to have broadly similar resources, environments, and populations, they still have very different outcomes of monitoring, detection and response to patient and deterioration. And if we look, for example, at failure to rescue in surgery, hospitals can have very similar rates of complications. Complications arise in surgery. That's kind of a feature of surgery. but they have very different outcomes once the complication has started to occur. And the thing that is making the difference is the process. Can you recognize and manage the complications? And that is critically dependent on teamwork, communication, and culture. This paper, for example, suggested that in older people, the macro level hospital resources, so this is the structure end of things, is explaining about 30% of the variation, and the rest of it is down to variation in process, things like the way that care is organized. So it's absolutely clear that interpersonal and organizational dynamics are key drivers of what happens to the patient, and the ability to implement personalized care interventions effectively. But they're not the only thing. What's also critical here is this organizational dynamics end of things, and in particular, process design and how that gets challenged by operational failures. Brilliant paper from the US estimated that about 12% of nursing time is spent on operational failures. They're dealing with constant interruptions and having to search around the place to find the information they need, test results not being available when you need it, equipment not there or not clean or not available, and vast amounts of time spent looking for keys. When we have done the same job, we've done the same research in primary care, it's exactly the same phenomenon. GPs spend a really quite significant proportion of their time dealing with operational failures. Some of them arising within their own practice, but many of them arising because of their role in coordinating care and having to deal with IT systems that don't work, notes that just aren't available, letters that are supposed to have come in from the hospital, and so on. Also linked to this is how patients interact with the health system, and how access really happens is much more complex than a simple matching of supply of appointments to patient need. There are all kinds of things which we've called candidacy driving, how it is that people come to identify themselves as candidates for care, and that's very socially, economically, and ethnically structured. Their capability and resources for navigating services, the extent to which those services have permeability and can be accessed easily, how they present at services, how their needs are adjudicated, and how they respond to offers and resistances. And that all has to be built into the models of care and the work systems that is eventually going to deliver. So beyond that, the process design, there's also the bigger impacts on services of bringing in personalized approaches. Most evaluations focus on a singularity. They focus on the thing, and they seek to evaluate that one thing from the perspective of the thing. But we need a much more holistic assessment of what's going on. Again, our colleagues in the Health Foundation produced a fantastic report just a couple of weeks ago describing how stressful it is in general practice at the moment and how much time is spent on paperwork and admin. But one of the big things is the impact on access to care for people with symptoms can be disrupted and undermined by trying to provide care for people who don't have symptoms, and you're trying to do the true discrimination on people who don't have symptoms. So that kind of more holistic assessment currently is not happening, but the BMJ has been calling for clinicians' time needed to be the time to treat people with symptoms has to be considered in the round, along with the recommendations for finding everybody who needs statins and getting them on it, which I think is pretty much everybody over 55. We could say, well, can't quality improvement save us? Can't we just get personalised care to be delivered more reliably, better by improving systems in care? And here is where my research mission is focused, trying to produce an evidence base for how you do healthcare improvement. And it remains tantalizingly difficult to answer the question, does quality improvement improve quality? Because we have just not had the research base built up about how to do it. So, the Health Foundation has had huge vision and foresight in funding this institute, and our job is essentially to create that evidence base and also to build capacity around the UK. We funded over 55 fellows at other universities to develop this area, and goodness knows it really needs that investment, and it needs a generation of people studying how to do improvement. What is clear is that changing processes requires structured methods, skill, and resource. You have to have a systems approach. You have to have high quality design. You have to satisfy the structural requirements, things like equipment, staffing, resources, supply chains, and that they need research attention too. You have to optimize tools and technology that people are going to use, and that often doesn't happen. It gets deployed without that optimization happening, without attention to validity, usability, acceptability, and implementability. But you need really full understanding of the whole socio-technical system end to end, everything from clarity on roles, responsibilities, and processes through to communication and relationships. What we've been doing at this institute is editing this series published by Cambridge University Press, and with some world-leading authors from around the world, including some in this room. And this is an overview of different approaches to doing improvement. So the evidence is beginning to emerge, and it would be great to see the momentum build behind it. What we still have, however, is way too many poorly supported top-down improvement directives, basically people being told what to do, not necessarily how to do it. Some of these improvement directives add to the challenges by creating the problem we call priority pickets. So there is so much flooding into the system that it becomes impossible for organizations to have any clarity about what they're looking for themselves. They spend all their time reacting to external imperatives. And if we look at maternity alone, they had 1,500 different recommendations in 1 year, no sense of prioritization, and they are recommendations, not solutions. So if you think each of those needs some kind of work system design, that you need to do all that business of tasks and roles and training, this is not a sustainable way of doing anything. And the answer too often is, well, just grow more hands. We have the allied problem that standards, externally imposed standards, are like toothbrushes. Everybody wants a standard, nobody wants anyone else's. The other problem is that we have way too much poorly supported bottom-up improvement effort. And an awful lot of this is done by junior doctors who are forced to do quality improvement projects as part of their portfolios. That favours small individual projects where they're supposed to be leading, but it leads to reinvention, waste, and often suboptimal solutions because inevitably one person doesn't have the expertise you need to do a lot of this work, and a failure to learn from other areas. So that we've basically got, again, the same problem of improvement waste, a proliferation of small projects done by people to tick a box in their portfolio. So where do we go from here? How can we solve this challenge? I'm going to suggest to you that the future is co-design on a very large scale, and that we can do an awful lot better with co-designing what good looks like for personalised care. It is sometimes the case that people don't understand what they're aiming for. The different actors have different priorities. One of the things we've done at this institute is built a platform we call Discovery, and we think the answers are out there. You just need to facilitate people to come together so you can co-design what good looks like and the solutions. And this really is very important. So for example, when we studied the shift to remote care for mental health, we discovered that service users, carers, and staff have very, very different views of what good looks like. And if you're going to design a service, you need to understand that. Similarly, if you want to co-design what good looks like for remote antenatal care and you consult with staff and patients, you get real clarity about what's important across the system. You can get to a common view. If you look at caring for, again, shift to remote care for people with COPD, we did a consensus building exercise, and that showed again that there isn't necessarily the same view between staff and patients. There are 14 standards of care. Patients and clinicians agreed on 5 of those being suitable for remote care. They don't agree on a further 5, and there's no consensus on the final 4. So that's very important. Build clarity on what good looks like that includes everybody. The second thing is that you can co-design processes and systems to support those shared visions, and you can do that at scale. Again, we've been trying to use discovery as a way of doing this. One example from the pandemic was the situation where you've got established clinical processes that need to be adapted for a COVID scenario. And one of these is the obstetric emergency of postpartum hemorrhage. We did this by shooting a very short video, which we knew wasn't perfect, of what it might look like. We invited people to comment on how they would improve the practice that they saw. They made hundreds of suggestions, which we were then able to consensus build through 2 rounds of a Delphi exercise so that we could identify the top priorities for improvement. And that gave us 14 recommendations, which we were then able to use for an improved clinical process, which has had over 130,000 views on YouTube and been endorsed by the major professional bodies and by patient advocates. So that was a really key achievement in showing that you can build improved processes and systems collaboratively, you can engage diverse and distributed expertise, and you can do that at speed and scale. So we've now published that as a methodology, and we're beginning to apply it in many more areas of practice. What we have found is that if you're going to do good co-design, you need to build on sound theories of change, and they have to be informed by inclusive principles. So I've made it a bit of a mission to try to demystify theory and why it's very important if you're trying to improve care. Guess the animal? Yeah, I got that one. Now, my husband has been in a lifelong battle with the squirrels that appear to believe that the bird feeder is for their benefit. And when my daughter was about 5 and had just started school and was very impressed with rules and had also just learned to read, she came up with what she thought was a very effective solution. So we sat down and we took a theory-based approach to this. So it had 2 good things from the point of view of NHS business cases. We had a very clear goal and we could afford it. But it relied on 2 assumptions which we felt were flawed. First, that squirrels can read, and the second is that if they can, they will comply. And after some discussion, we realized this probably wasn't going to work, so set that aside. My husband then came up with a second idea, which involved a plastic bottle. Again, satisfied clear goal and resource. So the bottle was threaded onto the pole, and the idea was that as the squirrel ran up the pole, his head would get stuck, or her head would get stuck, and would be forced to withdraw. So that seemed plausible as a mechanism. We tried this, it appeared to work, and my husband then made the terrible error of boasting to our neighbour who edited the local newsletter, and the headline was not what he was hoping for. But this, because of the shaming effect of this, we never wrote up this study, and I was disappointed to see that a colleague in Australia has encountered a very similar issue. So his is that he's got a huge plate glass window. Birds keep flying into it and knocking themselves out. This one fortunately recovered. But I felt his solution had some defects that repeated my daughter's. So going back to why we need theory, we've already identified interpersonal and organizational dynamics are key drivers of failure to rescue. We know that teamwork is a really important part of this. There is a superb literature on teamwork, and developing cultures of high quality care. We kind of know pretty much how to do it. We have excellent studies from obstetric emergencies, from surgical mortality, and from operating theatres. So we don't need to start again with how you design a good team. We've got theories about how to do that. We also know that good co-design builds on examples of positive deviance, and we've been using this very successfully in this institute, starting with how to be a very safe maternity unit, which started with 1 very safe maternity unit, and we were then able to build that out using others to create the 7 features of safety. This has been a very influential bit of work. Good co-design starts from the beginning and is inclusive from the start. And we've been able to use this approach many times, but one of them is in an important program we've been doing for the Department of Health, avoiding brain injury in childbirth. And this has been trying to build an end-to-end system for detecting and responding to the baby who's not coping well with labour, intrapartum fetal deterioration. We've used a very holistic co-design approach to come up with a personalised way of assessing the baby that goes beyond simply looking at the fetal heart rate. Again, we've done much of the co-design, but not all of it on discovery, and we've worked with both staff and patients so that we can co-design the tool. The tool has used a lot of human factors expertise. It's absolutely critical to designing good systems. And for example, we produced 2 versions of the prototype tool and used Think Aloud interviews to get feedback. We're guided throughout from the very beginning by learning from women and birth partners about what good looks like for them. Extremely attentive to diversity, so trying to work with underserved and under-researched populations and make sure that we were checking for cultural competency. We ran simulation testing with over 50 staff and patient actors, including those from maternity voices. And one of the outcomes of that was that a key item on the tool is the woman concerned. So that has just as much priority as fetal heart rate or any of the other measures is the woman concern. I think we can also get better with co-designing better measurement for personalised care. Paula Williamson in Liverpool has been doing fantastic work developing core outcome sets for trials with patients. I think we can do the same for personalised care and for quality and safety. We can use methods like clinical simulation, which I think is underused, and we can actually just talk to patients. That can make a big difference. So it's 90 years since Tonsilgate. We've had 2 millennia of debate, but we still have unwarranted variation. And worse than that, we have unwarranted variation in the effort to reduce unwarranted variation. I think we're tolerating very high levels of waste in research, in design, and in improvement. And we think we're setting out to do something, but we end up with something very different. Ideas on this animal? Not an elephant this time. It's a hippo. So we need to, for personalised medicine to achieve its potential, we have got to address these problems. We need large-scale research, large-scale design, process improvement, and very importantly, evaluation. We need much more inclusion in how models, tools, and systems are co-designed. We need to solve the problem of many hands, which is the problem that we have actually no shortage of people in the system trying to do good things, but their efforts are not coordinated, they're not integrated, they're either dispersed into too many small-scale local activities or too much responding to large-scale top-down directives. So you may say that pigs might fly, but I think we have the solution here among us. Thank you very much indeed.